Ladies and gentlemen, we now move to part 5 of our fifth part symposium. The presenter for this is Dr. Andrew BROSTEK from Perth. Andrew's been involved in putting together the whole program for the Silver Wave, and he gets the challenging role of actually looking at the implementation side and particularly talking about the role of different members of the oral health team. And he's going to share with us his experience from private practice in Perth, but also a large number of much broader principles. So please join with me in welcoming Dr. Andrew BROSTEK.
Thank you. Thank you. Well, I've been selected because I'm the oldest presenter. I think that's my main credential for today, and it's certainly surfing the silver wave, making models of care, I interpret as how I can advise you how we've put MI into our practice, and in fact it has to be financially viable or we're not going to do it. So it's an important topic. I've been in practice for a long time. I've been an MI dentist for a long time. And this is, to my surprise, I found I had an elderly practice. In the 6 months since I've been tasked to do the lecture, I've been watching the patients, and I was quite surprised because I thought I had a very diverse range of age groups in my practice, but in fact the majority of my patients are elderly. And in fact, I am in a provider suburban practice, mainly with middle class and some blue collar patients. And in fact, over 80% of practice in Australia is still done by small, medium private practices like mine. In fact, in WA, the majority of practices, something like 80% of practices are provider practices. And that's the highest rate in Australia, bearing in mind we have difficult economic conditions in West Australia at the moment. So this is the wordy slide of saying that, in fact, 50% of the average patients attend a dentist in a general year, but in fact the good news for the 65 plus people is that 70% attendance is much, much better. And of that 70%, 85% attend general practice, which I'm very thankful for. But there's important things we have to understand, that the coming silver wave of medically compromised patients means that treatment demands in the future are going to be different. And the corollary of that is the notion that types of treatments of the past will extend in a linear fashion into the future is incorrect. And as a result of that, there are going to be challenges to our practice profitability. In fact, changes to our practice profitability. So for health provider practices like mine, where my fees are already constrained, and in fact, last year, the largest fund in Western Australia, called HBF, reduced our payment fees for the first time. So there are difficult conditions, and I have to fit that in with my MI. And if there are 2 slides that I could tell you will relate to my topic of financial success in private practice, as other speakers have also mentioned, is, are your patients just numbers? And I say that because it's all about relationships, and that's particularly for the elderly. And as clinicians, which most of us are, we're very conscious of relationships and forming that communication and the bond. But are your front desk, do they have the same attitude? It relates from your front desk all the way through your practice, your DAs and all your staff, because the critical part of a profitable practice is showing you care. Because caring is the key message. Again, I'm very pleased to hear the theme from other speakers that in fact what we rely on in my practice is an MI clinical framework, but without empathy, without compassion, it's going to fail. So a key message is caring is how we show care. And again, Anthony was talking about the 3 C's. My 3 C's are slightly different. Competence, commitment, compassion, but I'm certainly going to increase it to 5, communication and connection. But it's about caring is how we show care. It's a very important message. So I started out like this. This could be my work. 35 years ago, I was trained as a GV black dentist. And this was inexpensive care. Amalgam is fairly cheap, and the patients may not have liked the appearance. But I'm part of what we call the heavy metal generation. And the problems we have are there's no recognition of the biological basis of disease in this approach, and it's template dentistry. If I said to everyone in this room, I want you to cut a class 2 cavity in a premolar, every single one of you can visualise it, every single one of you can do it perfectly. But unfortunately, it's not about amalgam and GV Black, it's about adhesive dentistry, cutting smaller and not needing to do the things we did with GV Black. But the worst problem is late diagnosis of lesions. Late diagnosis, in fact, of disease means larger cavities. So my journey into MI began with aerabrasion. I went to the States, I learned how to cut smaller and smaller and smaller, and as the years went on, I realised, well, if we cut smaller, we get to the microscopic, and the microscopic is dealing with disease. In other words, MI dentistry. And what's interesting is the health data shows that prevention in Western countries does result in less dental disease. In other words, prevention does work, but what surprised me was approximately 1/3 of our dental income in Australia is from preventive procedures such as prophylaxis and scaling periodontal cleaning, from Thomas Fleming from Hong Kong University just last year, interviewed by, I think it was Ian. So if I give you an outline on my presentation, it's about models of care, clinical, it's about an MI approach, about treatment barriers and managing the elderly. It's particularly important in implementing MI model with what we call a dental team approach. And lastly, briefly, financial models of care, talking about fee-for-service and capitation, and in fact making your practices financially viable. We know what the problem is. It's well described that the challenge is that oral health is an important part of general health and quality of life. Serious dental problems in the elderly are masked by dementia, high dependency, associated medical conditions and drugs. We know that. But cognitive impairment's even worse because it often leads to compromised daily oral hygiene. And that, of course, is one of the critical factors in managing the elderly and keeping their teeth. So if we start with treatment barriers, non or poor attendance, physical or mental disability, and just out of interest, one of my colleagues at the University of Western Australia was published in the ADJ just this year, and mental disability with much lower toothbrushing rate results in poorer oral health and potentially higher dental costs. And we're talking about costs. In my own practice, getting the patients to my practice, suburban practice, is reliance on carers for travel for some of my patients. Some of my patients are resident in care facilities, and worst of all, in terms of lack of affordability, in fact, the poor poverty levels, I think that Ian spoke about in his presentation. So we have a number of problems, but in terms of my topic, I have to talk about overcoming barriers of care in terms of financial aspects. And our aim should be to make care more affordable. We know that simplified preventive and restorative care reduces cost to the patient and should enhance patient access. Correct. I've often heard Melbourne dentist, Dr. Jeff Knight, and he's often said over many years, if you can do your dentistry and do it better, if you can do it faster, you should pass on the benefits of making it cheaper as well. And I think that's a key part of minimal invasive dentistry and what we're talking about. And certainly, in other words, it's always cheaper to prevent than it is to restore. And I think that's another key message of what we're talking about today with MI. So our best clinical model of care is minimal intervention dentistry, and there are two main parts, as you can see. Maximum interception of disease means two things. It means managing the risk factors, identifying them. It means protecting at-risk surfaces to ensure adequate cleaning. And that's something that sometimes we forget, that second part, as I'll demonstrate later. And of course, minimal invasive dentistry is in fact minimal invasion of patients' tissues and trying to avoid irreversible treatments. But with respect to the elderly, there's a third part to MI, an adequate dental review program, particularly following major medical events or, in fact, patients with severe frailty as well. And these are the things that we recognise are particularly important. So one other presenter talked about rapid changes in caries risk, and if you look through the yellow writing of lifestyle changes and major medical mal-events, the patient behind there had the implant dentistry done by me about 2 years before he retired. He then retired. He drank a lot of wine. He had a wonderful life. He ended up in a facility with his wife at the age of 76, and he had a low resting pH. And what you can see in the circles are very rapid lesion development and disease development. So we do know that changes in lifestyle, changes in life and mal-events, but most important of all, you need to tailor care to the individual patient, as other people have spoken about already, depending on their particular health. So this particular patient is the second one I wanted to present to you. He's my age. 2 years ago, he presented and was diagnosed with Parkinson's disease. You can see that, in fact, I've placed Fuji-7 EP reservoirs, and I've got him on Neutrophil 5000 toothpaste. But if you look at the problems that he has, you can see that we're really battling the problems. We're battling the polypharmacy. And when he walks into my practice now, he has to use a cane. He hobbles up the corridor and, in fact, has difficulty using his arms and difficulty speaking, all in 2 years. Rapid change in caries risk is something we need to identify in this particular patient. And of course, I'm using MI varnish with the CPP-ACP. And again, in the literature, it's well supported that it seems to be durable and seems to be doing it quite well. So of course, we're recalling him 3 to 4 monthly for a clean varnish. And of course, using Fuji bulk in those large lesions that you could see because it's acid resistant. So how do we enable patient empowerment? Where possible, we need to give ownership to the patients, and that's really important. And as other speakers have said, it's particularly important to try and retain their teeth for social and functional reasons. But it's the unfit patients that we have to really watch out for, because family and carers must be brought into an understanding of the rationale behind what I'd call appropriate dental care. And this is a picture of a case from Alan Deutsch, who is a Sydney dentist and does a lot of work in his dental clinic in a care facility in Sydney. And he uses a lot of silver fluoride because that is the best way of managing the lesions in demented patients or very ill patients that are bedridden. But it illustrates the importance of communicating with the family, who will be very upset by that appearance potentially, and want to understand why you're doing this. Is it appropriate care? And this is a patient of mine just last month. She's 87 years old, dementia patient. Her daughter brings her in, and if I lift her lip, she starts screaming at me continuously. Management I can only do is this type of management to help her out, and in fact the daughter understands it. So communication, as Anthony was talking about, is a particularly important part of what we're doing in terms of management of the elderly. The flip side, the opposite, is Rafi, who turned 104 about last month. He is the oldest patient in my practice, and he's in amazing health. He's self-empowered, he's very healthy, he's not on any meds, and in fact is wearing a full denture. We've tried desperately to keep his teeth, and we know that the lower overdenture, although the teeth aren't symmetrical, in fact we've retained with GI doming, or what we now are calling bollards. And I used Equiafort in this case, but now I would use Fuji bulk. He's very happy with his ability to eat, and he's in an excellent state of well-being. In fact, what it means is he's got excellent quality of life. And in fact, until last year, he drove to my practice every day, walked down the corridor, pays a bill, and leaves. Every 6 months, we put fluoride varnish on his teeth, and we very happy to see him. He also goes on a ship's cruise every year with a girlfriend. Unfortunately, because he's living so long, he has to change girlfriends. But he is a very healthy man. So I did include this picture of bollards in Perth in Western Australia purely for Ian, because Ian, as you know, has a particular interest in bollard dentistry, being a bollardologist. So there's your picture of, we do have a lot of bollards in Perth, and use them often in minimally invasive dentistry. So in all seriousness now, what is the important thing about my practice is our centre of excellence is our biological approach to disease. And everybody's been talking about identify number 1, number 2, protect and prevent, number 3, treat and control, number 4, maintain. But it's about the MI clinical philosophy. It's about prevention, it's about appropriate dentistry. But in fact, in my practice, MI is the base, but we build all advanced dentistry on top of it. I have an interest in laser dentistry, we do implant work, we do everything. MI doesn't preclude conventional and good advanced dentistry, just as a point. So if I could introduce you to an article that in fact hasn't been published yet by Laurie Walsh called MI Management of the Older Patient, to be published in the BDJ, British Dental Journal, in the next month or two if you get an opportunity. It really is a terrific overview of everything you need to know about, in fact, this what we're talking about today. And it talks about the MI, identify risk issues, prevent disease, minimum invasion of tooth structure. That's what we've all been talking about. But it's the latter two that we often miss in my practice. And the latter two is engaging the patient and enabling others, because it takes time. So creating an appropriate long-term dental program, again, we have to do it, and we'll talk more about it, but also compiling what we call a written passport to cover the advanced treatment that's in the patient's mouth. So the carers or in the residential care facilities understand what's in that patient's mouth, and certainly IDing the dentures as well. But the last two are the particularly important ones, and that is training the carers, even the nursing staff, in personal oral health procedures, and lastly, communicating, again, the need for regular dental care to the family and to the carers of the patient are things. So I ask you, how can we best achieve these outcomes? And the answer, I think, is, in fact, the second part of the lecture, implementing the model using the dental team approach. And what we talk about with that, and I'm sure everyone in this room will agree with me, the most important part of our practices are our staff. We have 2 dentists, 2 hygienists, and some part-time girls, and some reception staff. But because of our small size, we have the benefits of good communication and the ability to change our procedures easily. So that is a good thing in terms of what we need to do. But every dental team member has a specific role in terms of incorporating MI and implementing it into our practice. So our dental team approach shows you roles for everybody, from the clinicians to the DAs to the front desk staff. And you would think our goal was just about disease, about identifying and treating disease, but it's not. Our focus is a focus of maintaining the health of the patients. We're not just dentists, we're health professionals. We're interested in a holistic approach to the health of the patient. And it seems obvious when you say it. So we try and focus on all of that and not just disease. So what is important in terms of the profitability of my practice is that the dental team drives the efficiency of my practice. The hygienist or the OHT or the DAs, they take the photographs. They do the documentation. They do the special testing that we want to do. They do the assessment and the explanation. Of course, I'm coming in and also explaining and supervising as well. And in fact, that delivers the time efficiency. That in fact delivers the profitability to fund the MI model in my practice. I think that's a key thing. You can call it an oral health team or a dental team, but that is a key part of what we do. So, there's my hygienist talking to a patient. It's very important and a useful thing to have a third party to talk to the patient, because the patients trust the third party sometimes more than they trust the dentist. Education is, of course, improved. Message reinforcement, of course, occurs between myself and the hygienist as well. And certainly, because they're doing the roles that we'll talk about soon, it enables me to get a higher financial return on more advanced treatments by allowing me the time to do those instead of what they're doing, or partly what they're doing. So this graphic is in your booklet, in your Silver Wave book, and it defines the front desk role, the dentist role, the dental hygienist OHT role, the dental assistant's role, and of course the very important thing of setting the recall appointment. But rather than show you one graphic after another, I thought we might introduce you to Josephine, who's 84 years old, sitting next to her husband, Sydney, in the in the waiting room. And of course, the roles of the front desk are identity confirmation, adequate communication has to be established. The carer, we have to establish very good contact details. Of course, the medical history form. And staff attitude is so important, as I mentioned in an earlier slide, because the front desk staff have to take the time and be empathetic and try not to be rushed when the phone rings and the toothaches walk in and other things that happen. So it's about caring is important to show a personal interest at the front desk at that initial contact point and start to develop the relationship. So the geography, the practice map is similar to any of yours. We have a front desk, we have rooms for the hygienist, we have rooms for the dentist, and of course we can move the patients around in any direction we want. We can send them to any operator and of course between the operators, and nothing that's quite standard. So let's send Josephine from the front desk to myself. And of course, the roles of the dentist you should be very familiar with. We're diagnosing radiographs. We're diagnosing and reviewing the special test results and of course, information. And of course, complex dentistry. That's what we like to do, and that's what we do in all the facets of dentistry. But it's the last three that I find interesting. The responsibility for communication with medical staff and dental specialists or external specialists takes time. Determining appropriate care with oversight of optimal treatment plan or plans also takes time. And the last one, which in my practice we don't do particularly well until now, is a regular watching brief on major changes in the medical history and increasing risks of oral disease, because we're sometimes constrained by the software that we use within our practices. So of course we come back to what other speakers have spoken about, that in fact it's recommended at the age of 75 that you perform a comprehensive oral health assessment and a long-term treatment plan prior to the patient becoming frail or entering a nursing home. You want an OPG, you want an implant passport we talked about, and denture ID. But we all know it's not about just 75, because the health of a 60-year-old or a 55-year-old might need earlier implementation. But in my practice, because we're doing so many things that dentists have to do, sometimes we tend to be reactive and we tend to forget to do this. So at 75, it's important to draw a line under that and say to yourself, I really need to protect this patient for the future. So in her examination, she's in with me. Unfortunately, she's got mild dementia. She's got severe arthritis of the wrists. She's hypertensive. She complains of xerostomia and hyposalivation, and her meds are antidepressants, antihypertensives, and methotrexate. And when I look in her mouth, I see not just high caries risk, but I see multiple caries lesions around teeth adjacent to upper and lower partial dentures. And now part of that is due to her wrist arthritis, inability to maintain oral hygiene. And she has a large social problem because she's very upset that she cannot remove her upper denture because it's anterior posterior, as you'll see. And that's very important to her and important to us. So of course, when we interview her and when we see her, the husband is in the room because she's got the mild dementia. Because we have to overcome confusion about treatment, we need to have covered issues of consent if it's just dealing with her alone, and lack of cooperation. Fortunately, she is reasonable, but it's important for carers and family to understand, again, the need for ongoing regular dental care. And I think it was Laurie who mentioned in his lecture very large increases in the mid-80s in terms of dementia rates, and also in the 90-year-olds as well. And Sydney and Josephine live together at home, and they have a son in an eastern state city, and unfortunately Sydney has terminal prostatic cancer. He was admitted to palliative care last week, but fortunately this was done a month or so ago, and we had a good conversation with both of them about the need for future care and carers for Josephine. So it's really important to have everybody or other members of the family to talk to if you can't speak correctly to the patient. So in my practice, this is what we do. In every examination, step number 1, identifying. We carry out a caries risk assessment. We do it for all patients, but particularly the elderly. And of course, Josephine has lots of multiple cavities. We have to meet her drill and fill expectations. Of course, that's what we're going to do. But the most important thing you can say to any patient is you have a disease and we need to analyse the causes, we need to carry out diet and lifestyle tests, we need to, in her case, do a saliva test, and certainly a plaque test. And what we do, again, every patient has an initial caries risk assessment where they're divided just into 2 categories. Low risk, routine restorative treatment, a scale and clean fluoride. But it's a second category of high risk, and she's extreme risk because of the hyposalivation, is a detailed caries risk assessment which allows us to target and tailor individual treatment for that patient, including medications that we particularly want. And that's, of course, what we did with Josephine. So we've now at another appointment. She's had the initial appointment with me. I'm referring her to the hygienist through the front desk. And one of the problems we have at the front desk when they are making their next appointment is they don't often want special tests if they haven't understood what we're trying to do. So the way we get around that is to take some of the special tests and put them into a cons appointment. We don't have a special separate detailed risk assessment appointment. We move the dietary assessment or other things into routine appointments and then get our information that way. And here is the roles for a hygienist that you all should know backwards: education about oral disease, debridement of teeth and oral hygiene instruction, carrying out the special tests we talked about, periodontal charting, screening for changes in oral disease, and of course application of topical products, fluoride varnish, and tooth surface protection that other speakers have talked about, all within their delegated treatments within their scope of practice. And now we come back to the financial aspects of all these codes, which I think is on the bottom of page 45, with all the codes of saliva test 047, diet assessment and advice, plaque disclosing, MI varnish, etc. You can look at that. But these are codes that OHTs and even hygienists, dentists, we all can carry out and use these codes, and we should. So this is not a picture of Josephine's plaque test. I unfortunately didn't have it, but this is a very important thing to do using a unique product, GC Triplaque Gel. It's unique because it has glucose in it. And because of the glucose in it, it gives us that third light blue greeny colour. And what that is acidogenic, cariogenic active caries going on with that bacteria because they're eating the glucose, changing the colour. And what would you do if you rub away that blue spot? What do you have underneath? You have a white spot lesion or a carious lesion. So that is active caries. It's a simple measure of education and empowerment for our patients or for the carers and the family, an important thing to do. And again, we know from the literature, in terms of maintenance of oral hygiene in the elderly, the problem is amplified with advanced age due to declining fine motor skills and reduced visual acuity. So they're the sort of things that everyone else has sort of been mentioning. It really is about oral hygiene maintenance. And of course, as part of step 1, my hygienist is now doing the detailed caries risk assessment, and she's doing a saliva test here. The problem with Josephine is a resting pH of only 6. She's demineralising as she's sitting there. Only less than 2 mil of stimulated saliva. So the problem with her is she really is a high risk and has problems with the saliva and the polypharmacy. So what about the risk assessment appointment? We've discussed that at that appointment they're doing the tests, analysis of a 5-day diet sheet including the weekend, doing the scale and clean oral hygiene. We gave her an angled toothbrush with a thicker handle, but certainly electric toothbrush could certainly be an option. The hygienist applied the fluoride varnish after and the prescribed medicaments that we chose. And unfortunately, we did prescribe her Tooth Mousse Plus, CPP-ACFP, but we're concerned because of the mild dementia of compliance. And she won't chew Recaldent gum. You'll find a lot of the elderly won't chew gum for social reasons, or in her case, she's wearing partial dentures and it's difficult. So we didn't prescribe it, and of course, we put her on a shortened recall appointment, recall of clean and fluoride varnish. So we're starting to talk again about step number 1. Identify the disease is these tests here. Number 2, protect and prevent are in fact applying the varnish and the other things that we talk about. So we keep coming back to the same management of the patient, and now documentation is a key part of what we do. This is just a 2-page empty sheet on the left and a sheet on the right of our diet sheet. And on the left, they write down everything they eat and drink for 5 days, especially between meals. We're interested in the number of acid and sugar exposures, particularly between meals. But if I could recommend to you this second sheet of distinguishing between coffee, tea, soft drinks, fruit juice and water is a wonderful way of determining the risk and determining and modifying their lifestyle and their diet. So that's how we do it, and we document it with the free sheets that are given out from us from GC. And in fact, this page on the left was designed by Hien No and Laurie Walsh, called the traffic light system, and it's a risk assessment for caries, and it has all the categories of attitude, saliva test, biofilm, fluoride, and giving an overall score of the caries risk, a red, a yellow or a green. And of course, the most important thing with the elderly is writing it down for them. You have to write it down. They will not remember what you've told them. So of course, in her case, we put her on twice a day of Neutrophil 5000 toothpaste. If that irritates her soft tissues, there is a low irritation fluid, Neutrophil 5000, that's available, and a weekly fluoride rinse if we can get her to comply. We asked her to drink more water. We told her not to have honey in her tea. And of course, we're trying the Tooth Mousse Plus and hoping that she'll apply it twice a day if we can. And GC dry mouth gel with its high pH, or even Oral 7 that patients find is a very good lubricant. So it's important to do these 2 steps, and of course it's very important to document it for legal reasons and for helping the patient as well. So we're finished. We now got her from the hygienist to me, where I'm going to have a look in her mouth, and the first thing we see is ring barking carious lesions, which we'll call number 3, treat and control. And this is often caused by dentures, as you know, but look at her plaque. There's plaque there, and I'm going to restore that with Fuji Bulk because of its acid resistance, and I think that's reasonable to do, but it's also, as I think it was Ian mentioned, that you can apply medicaments via the denture as well, which sometimes we do, but not in her case. The other side I find particularly important in deciding on cost-effective, appropriate treatment. You can see a 3-4 and a 3-5, extremely heavily restored. Should I crown those teeth based on her problems in her medical history, based on her risk, or should I carry out minimally invasive treatment? Of course, in this case, I succumbed to aesthetics and I used, in fact, Fuji Equia Forte, but certainly Fuji Bulk would be more acid resistant. Equia Coat is probably not a good idea on reflection, because I want to see her GIC dissolution rate. If this dissolves very rapidly, it's telling me she's not cleaning. It's telling me that she's got a highly acid environment. But certainly I wouldn't crown these teeth. And from the 1990s on, cost-conservative dentistry, appropriate dentistry at lower costs from Smith, from Westerman. These are all important things in deciding on appropriate care for your tailored treatment of your patient. So the other area of interest was her upper partial denture that's creating a low oxygen tension under the chrome denture in the biofilm and a low pH in the biofilm. And she's got the arthritis as well. So when I look at that, it's about number 3, treat and control. You can see the caries there. I can easily put a GIC, small, minimal invasive restoration, but I need to do more because an important part is protect and prevent. I'm going back a step. I want to recontour plaque retentive areas. I want to remove the undercut, in this case using Fuji 7EP. And every year or two, I can check it and I can add more if I need to. And the denture sits over that and it solved the problem of part of her arthritic and oral hygiene. So it's a very important part. And again, in the literature, in Laurie's article, this emphasises the importance of reducing plaque traps in the mouth by reshaping teeth and assessing the relevance of retaining posterior teeth. So it's all part of our management of the patient and an important part. And here, now you can see her upper partial denture and the fact that she can't, when it's in there, she can't remove it because of the locking effect of the anterior tooth. So of course, part of my future treatment plan when things have settled down with Sydney is in fact to cut off that anterior tooth, and I was considering either a Maryland bridge or a fibre reinforced bridge. If her care deteriorated, if she was put in a home, I would advise her not to wear the dentures at all because she retains her appearance and she's got her 5s, up to her 5s, but she certainly can continue wearing them at this stage. So we come now to the roles of the DA, which unsurprisingly are very similar to the hygienist OHTs. They can do intraoral photography. They can take impressions of study models, as I'm sure yours do. They carry out plaque disclosing and cleaning dentures, oral hygiene instruction, of course, testing salivary parameters, and assessment of diet and lifestyle. So here's my favourite nurse, Susie, who I need to rely on, who's had a baby and only works 3 days a week, so it's difficult. And here she's got 93-year-old Dulcie, who lives in a residential care facility. And she's demonstrating cleaning of teeth, and the daughter of Dulcie is sitting in the corner watching this. So I was lucky enough to use the Tri-Plaque ID gel on Dulcie. So the daughter said, "My God, Mum, what are you doing?" And Mum said, "Well, in the care facility, the shop that sells toothbrushes is only open 1 hour for 2 days a week, and I can't get to the shop and back physically, so I don't have a toothbrush." So the daughter, of course, we supplied a toothbrush. The daughter, of course, asked us to clean the teeth. But she also asked us to contact the care facility and try and get the carers in the care facility to clean her teeth. So I think one thing all of us in private practice can do is we can offer training to the carers at these residential care facilities. There are 2 facilities in our area. It's not expensive for me to ask my hygienist to go for 1 hour to train the carers, who often have poor oral hygiene themselves and don't understand the importance. So these are the sort of factors that we need to think about as a responsibility for private practice. And in fact, the challenge of providing timely and appropriate oral hygiene care in these residential care facilities is dreadful. And it's state programs, federal programs, but the late Jane Chalmers, who I was lucky enough to know, who was a geriatric dentist who taught in the States, and she introduced MI in the 1990s and early 2000. She found in her studies dental hygienists could be a cost-effective option for dealing with oral health problems in these RACFs. It's an important role for dental hygienists and OHTs. Hopcraft, who we've been talking about a little bit today, showed that dentists or hygienists had similar diagnostic abilities to detect oral disease. So there's not a substantial difference, and that's why they have a particularly good role, I think, in residential care facilities. So we do know it works, okay? We know that tailored preventive oral health intervention, number 4, maintaining. Step number 4, a tailored oral health intervention significantly increased the cleanliness of teeth and dentures amongst the elderly. This was a huge study done just late last year in Age and Ageing Journal. It's an ongoing problem, but we know that tailored preventive oral health works, and that is part of maintaining the health of the patient. So now I've finished with her, I've referred her to the front desk, completion of immediate treatment plan until she comes back eventually for the anterior resin fibre reinforced bridge. We're still number 4. It's so important to set the correct recall period. And we know with the elderly, an annual dental check is essential for detecting disease or cancer risk. The average for our elderly patients is about 6 months. But obviously with Josephine, it's 3 to 4 months. And in her case, I think it was 4 months. And as needed, you need to change the recall periods, of course, dependent on the health events in the patient's life. So, what does the front desk do when she goes out there? I always remember Hien No used to say to us, you're not selling medicaments at the front desk, you're prescribing medicaments, and that's what we do. It is a profit centre for our practice. We sell a lot of the products that we want the patient to use. But in fact, it's about prescribing. It's important to help fund MI, but it's also important to answer MI-related questions. So that's part of our MI approach. And of course, the role of the front desk is, at the end of treatment, arranging the recall, reinforcing the need for regular attendance. The reception desk staff have to understand the overall message, provide the medicaments. In fact, both Josephine and Sydney understood the doses and the uses, and of course follow-up phone calls perhaps a week later to see, all the while not rushing. It's not an easy job being a front desk receptionist, and may I suggest to you that you look at the temperament of your front desk staff and select them accordingly. It's a difficult job. So, we've talked about how to do it. What do the patients think? Do the patients value MI? GC's Alex Cipriani did a study with Wendell Evans, Stacey Carter, Anthony Blinkhorn on 8 New South Wales dental practices that were carrying out preventive dentistry. And she interviewed a lot of patients. And the patients she interviewed realised that preventive care was better than the old drill and fill, and that general oral health would be better. They understood that it required ongoing changes in their daily routine, took time and had a cost. What I found most important were prepared to pay to keep their teeth. For the first time, these patients felt in control of their own health and were prepared to attend regular appointments. Good for them and good for us. So this, to me, is validation of what we do in my practice. Validation of the MI model by creating value in the patient's mind and letting them understand. So you'd think in terms of barriers to care, how can we best implement change in your own practice? I want to do it. I think you should be convinced by now from the excellent lectures of the others. How do I do it? I'll try to do it. I can do it. I will do it. I'll be successful in introducing it. Most important thing is adapt with small changes. Instituting one major change per month is one method of doing it. But you wouldn't realise that one of the most important things in MI implementation is you need to have a champion or a leader in your practice. You need someone to drive the ideas and keep an overview of what you're trying to do. For example, we have regular staff meetings to review and improve implementation. When we started, weekly meetings, then monthly meetings, then 3 monthly meetings, and now we've been doing it for so many years. We meet every 6 months and check to see how we're managing our implementation. And example of that was what I discussed earlier. Patients were not booking in for risk assessment appointments, and we found a solution to that by talking to the staff. And I must tell you, the staff know more than I do of what's happening in the practice, and they teach me, even though I'm supposed to be the leader and the champion, as I'm sure you'll find out. So the key to success: develop a consistent MI message to all patients. Develop value in the patient's mind is a critical part of what we do. So that leader, that champion. Surprisingly, we talked about barriers at the beginning of the lecture, but barriers include dentists' attitudes. In the same 8 New South Wales practices, Sabriani found in 2013 that the dentists believed that some of their patients were too unreliable to benefit from prevention. Certainly, dentists believe that the only tangible restorative treatment is the value that the patients sought. And that's why it's so important in communicating and connecting with the patient. So her resources were needed for adaptation process. You needed financial viability, you needed appropriate technology, time, supportive team relationships. Her conclusions were, it can be done successfully with effort, motivation and coordination. And that's interviewing the 8 dentists who were running MI preventive practices. So we know it can be done. And in your brochure there are facts to be identified, and we've talked about who is influential in your practice in terms of being a leader, who is part of your support team and be crucial during the transition, things that are important to facilitate that transition within your practices. You can do it. And existing barriers, like we just discussed, that can slow down the transition to embracing the silver wave patient base. Also, physical environment is important. Becoming an elderly-friendly practice in terms of ramp access, handrails. I did laugh a little bit about designing a peace and quiet waiting area. Our waiting room will never be a quiet peace and quiet, but if you can, that's an excellent idea. So here are my staff, some of my staff, and I think you can see we have a substance abuse problem in the practice. In terms of caffeine, they claim that they need it to keep going. I can't understand why. It's so important, in fact, with the staff and I, to develop consistent verbal messages, to talk to the patients. Staff learn to mimic the standard messages, and to be honest, I learned to mimic their messages more than they mimic mine. And we train the staff to interpret the diet sheet data and the simple plaque and saliva test. We actually act like a tag team. They call me in, I say the same things they're saying to the patient. We often have the message reinforcement quite well done. And again, another little section out of your booklet of MI implementation. Again, the things we've talked about, that every dental team member has a role to play. It's not just about doing the hygiene for the hygienists and the OHTs, it's also they're a fundamental part of the adaptation process. The dental assistants, the reception staff are trained on the importance of preventive and maintenance and understanding what we're trying to do. And of course the patients have to develop value. There is an excellent, and I haven't enlarged it, but if you look at page 45 at the top of your booklet, there really is an excellent, how can I start the process, how fast or slow should I be, how long should a recall appointment, we'll talk a bit, and how can there be additional sources of income. They're all in your booklet, really download it, or if you can't get a copy, but certainly quite important. So, we come at last to the recall system. Implementing effective practice recall systems, page 44 on your booklet, a whole lot of headings. An effective recall system is a key to patient care and financial success. And we found that texting doesn't work. We text as recall most majority of our patients. It's unreliable with the elderly because they don't check their phones often. So we ring them or we send them a note. So the way you do it is important. And in fact, again, in the brochure, you will see a breakdown of patient focus and practice systems. And in fact, some of the speakers have related to communication tools, clinical examination tools, risk assessment tools I've talked about, overall treatment philosophy. But in terms of my topic, it's the business side, the practice systems, the daily logistics, the recall systems, the importance of a good one, appointment, scheduling, rationale, staff training we've talked about, but also having the preventive and restorative materials. And again, the same slide that others have shown you, I find it particularly important to have the triplaque ID gel and the saliva check buffer, and of course using the Fuji 7 EP, the Equia Fort, the Fuji Bulk, and of course the Tooth Mousse Plus, the importance of that with dry mouth and dry mouth gel and all the products. So if you're going to 1, identify, 2, protect, 3, treat and control and maintain, there is a specific range of things that you need to do. So I can complete the program today with financial models of care because it's an important topic if we're talking about MI. And I'm sure that all of you recognise our current financial model is fee-for-service model, and I'm sure all of you recognise the ADA Australian Schedule of Dental Services and Glossary, and it's so important. In terms of strategies for success, it's about learning the language and using the appropriate item numbers. Someone else explained that the elderly take more time to treat. You have to understand and use the important and preventive codes. How many of you know that there's an 054 oral mucosal screening? How many of you know there's even a 142 tobacco counselling? Because we're health professionals, we're not just dentists. But you have to understand the desensitising and all the codes. You must charge appropriately. This is the key to your profitability with the MI model. And in fact, knowledge and time create value that create the income for all of us, and it's so important. And again, in the brochure, facts to be discovered, facts to be identified. How long should a recall appointment be? Well, yes, it can take longer. Yes, patients, the elderly, prefer to avoid peak times of coming to care. And importantly, as I've already said, if your fees are constrained, as they are in my practice, familiarity enables better utilisation of fee for service procedures. It's really important. If I had to say one slide in terms of profitability, learn your codes, learn how to utilise them. It's interesting that age and costs of dental care are much higher in the 65 to 7-year-old bracket in terms of Australian federal government data. But this data is totally out of date. It's out of date because elderly Australians are increasingly retaining their teeth. Most health funds, certainly in Western Australia, reward dentists more for invasive procedures than they do for preventive procedures. And in fact, can we create economic inducements for best care? And that's an important role for the ADA as well, to try and discuss with the funds. Because if we don't do it properly, there are alternate models of care. And I bring your attention to a capitation scheme. And a capitation scheme means you get one lump sum of money. Let's call it $600 a year for that elderly patient. And that's all you get. What sort of procedures are you going to do with that $600? You've paid it. Are you going to do crowns that cost you high cost? Or are you going to do preventive procedures that are low cost? So it's a very interesting thing because it alters dentist behaviour. Capitation has a future focus rather than fee-for-service having a present focus. It contains outlays and costs in clinics, maybe fund clinics if you're working in fund clinics, and should offer providers flexibility. It, of course, because you've got that limited sum, emphasises the attainment and maintenance of oral health. It's very good for the patient's health. It's a very good system as long as we in private practice get adequate amount of remuneration in terms of that fixed sum of capitation. So we come back to the theme of what really I think is so important of showing you care. It's practice building, as I think it was Ian mentioned in his lecture. The elderly are brought in by their 55 to 60-year-old children concerned about their parents. They often watch the care of their parent and they often book themselves in as new patients. So I'll draw your attention to Leon, who came to me 8 years ago, 92 years old. He met what I considered was appropriate care in terms of affordability, in terms of accessibility, in terms of acceptability of putting those 3 implants and making him an overdenture. He's now 100 and things are not going as well, of course, because his visual acuity, his dexterity is decreasing. We have some recurrent caries in the teeth. But in fact, what he demonstrates with regard to the previous slide is, in fact, over time, all his children, his grandchildren, his great-grandchildren have become my patients, and his younger siblings have as well. So what I'm demonstrating to you with this particular case is MI is a financially successful model of care. You need to charge correctly for fee-for-service. You need to build and grow your practices because the MI model does work. So again, showing you the lifetime from the early age. Got 5 grandchildren. What do I want to do? When they're erupting teeth, I want to cover them with Fuji 7 EP to allow maturation of the enamel. When they have deep fissures in occlusal fissures, I would like to use a GIC fissure seal. When they have actual cavities that need restoration, I want to be minimally invasive and place a GIC or a composite. Over the lifetime of that patient, fluoride varnishing the exposed root surfaces, but most important of all, caries risk assessment, understanding and assessing for disease is going to protect over the lifetime of that patient. So we started with this. The results of this are minimal destruction of tooth, maximal interception of disease, and that's what MI is all about. And when you compare that to my mouth, the GV Black model, from small cavities to large cavities to crowns and endodontic treatment, and if you don't get the crown in on time or what we would rather now do inlay onlays, what do you have? You have loss of teeth. So I don't think there's any comparison. 1, identify. 2, protect and prevent. 3, control, treat and control. 4, maintain. And of course, this is all in your booklet, but I would like you, from my point of view and practice systems, to point out to you, your adaptation process will vary from mine. Every practice, it'll be different, but you still can accomplish it very successfully. And the second thing is make small changes, adapt slowly, and most importantly, persevere. So, has the MI financial model worked in my practice? Outstandingly, the answer is yes. Prevention comes first, then quicker, better, minimally invasive treatments we've talked about. All these points, an efficient dental team approach, familiarity with the ADA fee for services, improved recall and follow-up services will drive the health outcomes of our patients and improve our profitability. And the last point I want to make to you is, it seems like minimally invasive. It doesn't seem like you're going to be profitable. But the important thing is MI does not preclude or prevent advanced restorative care. It depends on your assessment of appropriate care in that particular patient. So the resource everyone's been talking about, go to the website gcsilverwave.com, and of course surfing the silver wave means recognising the oncoming demographic challenge that Laurie talked about this morning. Implementing MI within your practice is a key part of your response. All of us need to adapt. And the last point I'd like to make to you is it would be remiss of me to not speak of the late Dr. Graham Mount, who was the father of minimal intervention dentistry in Australia and GIC use. And because of him and his mentoring to my generation, I think we now build the silver wave. Thank you very much.